Um, Suresh, it's only you and I talking about supposedly the C-Tract trial, but I want to back up a little bit. Obviously, there was a C-Tract starts with the letter C, and you had a trial that started with the letter A. Um, is this trial a continuation, or is it looking at a completely different pathology?
It's looking at a different phase of the same condition, whereas ATTRACT, the first trial, was focused on the use of endovascular therapy to prevent post-thrombotic syndrome. This study is focused on once patients have the disease, how can we reduce their disability, improve their quality of life, improve their symptoms, and can endovascular therapy play a role there? So that's what this study is focused on.
Okay, so you don't think I'm sure there's many people out there already who say, yeah, of course, I can help these people. I can just, do, angioplasty them, stent them, do whatever, and these patients with chronic disease, they do fine. Why do we need a trial?
Sure. Well, I think that there's a number of reasons. First of all, in terms of the immediate results you get after some of these procedures, they indeed can be satisfying for providers, for patients. But in terms of the long term, we do know that over time, there are patients that develop narrowing or occlusion of their stents. There could be other issues that may pop up in the long run. There could be either continued improvement of the treatment effect versus some erosion of the treatment effect. And these things really haven't been characterized or quantified relative to the risks of the procedure. And so it would be great to know what's the level of benefit that's sustained relative to the risks. The other reason to do it is that there is a lot of attention, I think, nowadays on expensive treatments from the people that pay for them. And so developing a strong evidence base, I think, is very important to be able to ensure that we can deliver quality care to our patients if they have access to it.
All right, so let's go through. Obviously, when you start with a trial, the first thing you start with is what kind of patients are you looking for? So what are the type of patients you're looking to answer the questions of the C-Tract trial?
The patients we're looking for are those that have had a previous DVT, a previous blood clot, have developed post-thrombotic syndrome, and the disease is of at least moderate severity. So it actually affects their daily living in a significant way. And they need to have obstruction of the iliac vein, which we characterize as either total occlusion or at least 50% diameter narrowing.
All right, so you're looking for people who come to let's get down to the clinical thing. Someone comes to your office and, yeah, doc, I had a DVT, 5 years ago, and I'm having trouble working. My leg is swollen. When I walk, after a little bit, I get this bursting pain, etc. Or patients who have had ulcers secondary to chronic disease as well. So those are the kind of people you're looking for.
Absolutely.
Yeah. And do you think there's more of those people around that are having significant symptoms versus people who you were looking for in the ATTRACT trial?
Well, we know that there's a lot of them around. Let's say it that way. Unlike ATTRACT, it was a thrombolytic treatment, and therefore you needed to find people pretty soon after when they were diagnosed with a blood clot. Whereas in with this condition, many people have had it for many years, and so there is a large population of patients that's out there living with this disease. It's affecting their quality of life, and we want to be able to find the best ways to improve that quality of life. And so we do think there is a significant share of people out there.
Okay, so now we kind of define the people we're looking for. How do you propose to find these people? What various ways are you going to employ in the trial to find these people?
Well, we're using different mechanisms. First, there's the obvious routes of referral where people with the condition present to different kinds of providers. And so we have 22 sites around the country that have kind of multidisciplinary venous treatment programs. Generally speaking, they have an endovascular physician that does procedures. They have a medical physician that oversees anticoagulant therapy, someone there that knows about compression therapy, as well as a wound or ulcer clinic. Now, we are encouraging all of them to make their local hematologists, vascular surgeons, vascular internists, phlebologists, interventional radiologists aware of the study. And I think that we've largely achieved that at these centers, but we're going quite a bit further than that. We have forged partnerships with a number of organizations around the healthcare arena around venous disease, and they're helping us kind of advertise the trial to a much larger swath of providers. We will also be using our electronic health records in these health systems, with IRB approval, to kind of screen medical records to identify people who might have the condition that might want to have it treated. And this is going to be a long-term initiative. Again, this is a large NIH trial, and we will be successively increasing the intensity and diversity of our approach to finding patients.
Okay. Now also, I mean, it's kind of a loaded question because I know the answer already, but we want everybody else to know this too. Walk me through a little bit what, you've been presenting, and you were nice enough to give me some of your slides to present at the AVF meeting. Talk to us about the electronic type of recruitment that you have.
Well, so most of the centers in the study have an electronic health record system nowadays, whether it's Epic or Cerner or whatever. And we have developed kind of search terms that they can utilize to screen within their healthcare systems and in their medical records to identify a large number of patients. Now, in addition to that, we have developed a mobile application. So it's a smartphone app. It's available both in the Google Play as well as the Apple stores now, and you can download it. And basically, our hope is that providers that see these patients will download the app, and then they will have the ability to, in a completely privacy-protecting way, notify our coordinating center that I have a patient who might qualify. What we will do then is call the contact number, meaning the provider's contact number that they provide on the app, and find out, okay, does this sound remotely reasonable? And then connect them up with the nearest study site. And then they can go ahead and we'll help engineer that connection. The idea being then that we're not dependent on just the patients that present to 22 hospitals, right, but we really are accessing a much larger range of patients.
Right. And to me, what I liked about this was, yes, you're going to get to a larger range of patients, hopefully, but it is a relatively painless procedure for the physician once they identify a patient. It's not like they got to fill out all kinds of stuff and that type of thing. They need to just supply you with some basic information, and then the call center will do most of the work.
That's right.
So, and I think that's great. And that, to me, I mean, I do trials, you do trials. That to me is a very unique thing. This is not something that's been around that often with any other trial that I'm aware of.
No, that's right. There probably are a few trials out there that may use something like this, but certainly in NIH trials, we haven't heard a lot of it being done. The NIH is very kind of excited and interested to see how this plays out. But yeah, basically when you get on the app, you basically answer 3 quick questions and provide 1 contact telephone number for a person that we can reach. And that's it. And so the idea is that a provider can do it without breaking stride. We're not saying go back to your computer and find our contact info or our brochure or our protocol. The idea is that it's in your pocket. You don't have to stop what you're doing, really. You can do it very quickly. And really the amount of work that you have to put into it in the middle of your busy day is minimized.
Yeah. Now, have you considered, since chronic disease, patients know, they had a blood clot most of the time. Sometimes they don't, but they know they may have had a blood clot in the past. They know their legs bother them. They know if they've had an ulcer. Have you considered rolling this out to the public, so to speak, in a way that they can access and say, hey, I'm a patient that has this. Can I talk to somebody to see if I fit your trial?
We are planning on doing it. We have, in particular, we're thinking about making sure there's information available on some of the forums, online forums that are out there that tend to attract DVT and post-thrombotic syndrome and venous patients in general. We have kind of a social media coordinator here at Washington University. We have met with that person to just get some guidance on most effective practices, most compliant practices, to make sure we can do it in a way that everybody's happy with. But we absolutely will be doing that. I think it's a great idea. I think also something that's even maybe more impactful than just us reaching out is the fact that, again, we've got 6 partner organizations, and they have already, in terms of communicating, remember, we're researchers and we learn to communicate. Some of these organizations, really a big part of their role is communicating. And so I think that we're going to be leveraging their expertise, the fact that they've already built up populations of laypersons that are interested in venous disease, that may have relatives affected by it, so that we can try and get the information out. And really, they're going to be the ones that that put a lot of the information out there, and they're very excited about it, which we really appreciate.
Yeah, no, I think it's great. I mean, I think it, vein disease in general, it is a self-diagnosed disease most of the time by the patient. I think it's very prevalent. So are you anticipating that recruitment may not be as difficult as the ATTRACT trial, or you think it's going to be around the same kind of?
I think it's going to be very difficult. I mean, I think that these things are always difficult. And when you're doing trials that are comparing a more invasive treatment with a less invasive treatment, I think right there that creates quite a bit of challenge in getting these things done, because you need to have the patients need to feel like they're okay with the study deciding which treatment they get.
Yeah.
And that means the providers and people they talk to have to be conveying that message. And both consciously as well as subconsciously as providers, we do sometimes convey our biases or our general inclinations to a patient. We tend to be pretty opinionated people. And so on any given patient, even if we believe in both treatments, we might have a feeling of which one we think might be better for one patient. And so that's always challenging to present things in a really balanced way.
All right, so let's go through. You bring up the treatment options. So what is the choices, so to speak, that patients can be randomized to? What?
Yeah. So patients will be randomized to receive or not receive endovascular therapy. What all patients in both study arms are going to receive is standard compression therapy, which, depending on if they have an ulcer or not, is going to vary. And compression therapy can include both stockings to start with, typically, but also if stockings aren't working as well, there are devices, portable devices, for example, that can be utilized. There are other types of wrapping and bandaging that can be utilized. And so I think it'll be determined a little bit by the local practitioner's expertise, but additional compression adjuncts are allowed. In addition, in terms of medical therapy, we'll be making sure that the study teams review the history of DVT and make sure that the people that really do merit extended anticoagulant therapy are getting that extended anticoagulant therapy. There are also venoactive medications. There's a venoactive medical food that's approved by the FDA that can be utilized. For some people, pentoxifillin can be utilized. And then people who have venous ulcers are required to be managed in a professional wound care clinic. It's not just something that the doctor is doing in the office, but something that really gets that expertise. So that's what everyone is getting. In addition, half of the patients will be randomized to receive endovascular therapy that will consist of iliac vein stent placement, followed by a reassessment at 2 to 4 weeks to see if they're still symptomatic and if they have saphenous reflux. And if they're still symptomatic and they have saphenous reflux, then that can be ablated using intravenous techniques. And,
all right.
Yeah.
All right. So now, what is the anatomy that you don't want? In other words, what is some of the exclusion criteria? Obviously, IVC occlusion. How are you going to assess inflow from the infrainguinal veins? Things like give everybody a sense of that.
Yep. So all patients are required to have a baseline ultrasound, and if there is poor inflow to the common femoral vein, then they would be excluded from this study. And in terms of the IVC, the only thing that would exclude them is if they have obstruction of an IVC filter that's in there, mainly because the complexity and the variability around how you deal with that filter could be quite enormous. So, but even if they have an IVC obstruction or narrowing and there's no filter, they can still be included.
Okay, so it's not just stenting of the iliac; you're stenting the disease from the inguinal ligament up. If it goes into the IVC,
if it goes, then yes.
Yeah, you're gonna do that. Now, as an aside, I mean, this is the question which we're all wrestling with at this point, especially when we're doing studies, is what constitutes good inflow from the leg okay inflow and lousy inflow. And all of us say, you know, when I see it, I know it. But is there any guideline you're given to the people in the trial?
The guideline, there's guidance, but not necessarily proscriptive sort of specifics. What we've said is that really we would expect there to be one excellent deep tributary vein into the common femoral vein, meaning the femoral vein or the profunda should be a good looking vein, meaning 10 millimeters, you know, if it's the profunda, you know, 9-10 millimeters, you know, a decent looking vein. If either of those don't exist, then we would say don't enroll the patient.
Okay. All right, so we have the patients. You kind of gave us an idea as to which ones are your obviously the ideal candidates, the kind of candidates, and those who you don't want. How about the treatment itself? If someone is randomized to endovascular intervention, how standardized is that regarding stent, type of stent? Let's do during the procedure, and then we'll talk about after the procedure. So. Yeah. So someone's randomized endovascular. What are they getting?
Sure. So in terms of the device, again, all the devices, as you know, are currently, the current devices are off-label. So we're doing this with an IDE from the FDA. And what they're allowed to use is self-expandable stents made of Elidoloi or nitinol of at least 12 millimeters diameter.
Okay.
That's what they're allowed to use.
Okay.
And that gives them the choice, you know.
Yeah, politically correct, I would say.
Yeah, and I'll mention too that if we get approvals of venous stents this year, which hopefully we will be allowing and encouraging their use in the study.
All right, good. All right, so you're going to do that, and you're allowing, and you wanted them to stent obviously the entire disease, going from a common femoral all the way up to the IVC or
absolutely, yeah. And we required that they pre-dilate the venous segment well, and that they stent and dilate it well as well, because we know that under-stenting is just going to lead to a problem, you know, in the long run. So
right, no, exactly.
We're pretty specific about that.
Yeah, I'm surprised you're allowing even a 12 millimeter, but all right.
Correct. I mean, we're kind of what we've said in the protocol is that for the most part we think that most people will get 14s or above. However, you know, sometimes 12 does make sense once in a while.
Yeah. I mean, if this is really a narrow segment, you just can't get it open. I agree. Okay, so now you've put the stent in, and what's going on? What's the patient doing post-procedure?
Yeah. So what we've said is that people that are randomized to endovascular therapy need to get anticoagulation for the 6 months afterwards. We've strongly recommended that it be Lovenox for the first 1 to 3 months, and then transition to an agent that we would like to be twice daily. In addition, say aspirin as well.
Okay, so for, you know, I mean, you and I, we're into the minutia, but not everybody listening or reading this may be into the minutia. So explain to them why you are recommending Lovenox or enoxaparin for the first month to 3 months versus some, you know, DOAC or something else.
Well, we know that the occurrence of stent occlusions is going to be more likely early on because we traumatize the venous system, and we know that in the post-thrombotic syndrome population specifically, these are clotters, and the rates of stent occlusion are substantial overall, you know, in the history that's been presented so far. So we think we need to be on the more aggressive end of things. Coumadin, unfortunately, the levels go up and down, and during that immediate post-procedure period, reocclusions can be frequent. Rivaroxaban, in the experience of some people, and again, there's no comparative studies here, but in the experience of many of us, a once daily agent like rivaroxaban hasn't been that effective in doing that much better. We think a twice daily agent might be better, for example, apixaban. However, there's just not enough experience to know that yet. In our experience with Lovenox, while it's certainly not the most convenient or inexpensive drug to provide, from the standpoint of saying, well, we feel like we did the best we could, it's our feeling that right now that's probably the best choice. And we're recommending that it be started before the procedure. In other words, what we don't want is in the 3 days after the procedure, messing around trying to get the drug. We want them to really ideally start it before, then it can just be continued through the procedure period. And then ultimately, eventually, we anticipate that most patients will transition to an oral agent.
Yeah, no, and I think that's what most of us are doing already. And I think it's very important to start it beforehand, not just to get the level of the drug, but so that the patient feels comfortable, and you're not, like you say, that first day or two afterwards, they're overwhelmed and say, how do I do this? Can I get it, or whatever? So I think that is good. So are you mandating at least a month, or you're suggesting?
For Lovenox, we strongly recommend, and part of that, remember, is that we can't control the insurance situation.
No,
that's so we would have mandated it, except that it's also can be a burden, a cost burden on patients. Yeah. Some just can't accept it, So
so there is not money within the grant, so to speak, or whatever, for this to be paid for the patient.
Correct. That's correct.
All right, so so that may. I mean, because I would feel strongly, and you and I will talk whether or not there's any more room in the trial, because my center fits everything that you said. But what I want to say is that may be a point that if you believe strongly, and I kind of believe in the Lovenox strongly, that you want to make sure patients are going to be able to qualify before you enroll them, because I'd feel very bad.
Sure.
You did not, they could not get that, and they had a problem. I would feel that it's my fault.
Right. So what I'll mention is that what the study does is we have what we call a run-in period. So patients first meet the eligibility criteria. They're entered into what we call a run-in period of at least 3 weeks, where they all get provided kind of basic standard care. The idea being that some people may never have even tried compression therapy at all,
Right.
So during that time period, we do a pre-certification with their insurance.
Perfect.
That way we can provide them the information. We don't choose for them, but we give them the information on what does your insurance company say about, for example, paying for endovascular therapy. Is that going to be a problem? And then after the run-in period, we give them that information, and then they have the opportunity to choose to participate or not. That way, really, the patient is involved, and hopefully that addresses some of the issue with the Lovenox, though probably in this crazy world of ours may not address all of it.
Right, but when you're talking about the patients here, I'm going to just change the thought process that we've been talking about. I find that these patients are in general fairly well motivated to want something more than what they are doing already. And when you're talking about the recruitment, I think from a patient's viewpoint, I find these patients say, please, whatever you can offer me, I'm willing to try it, because their lives are miserable, and hopefully you're identifying those people whose lives, as you said, or their quality of life is affected. So I think from the patient's viewpoint, I think we're going to get a lot of buy-in. I don't think they're going to say, well, wait a second, I don't know if I'm getting a stent or not. I don't want to be part of it. I think they would take the chance and say, good, I hope I am randomized here, because, it sounds like it may help me.
Yeah, I agree with you. And I think also what we've done is build in follow-up visits at 2 and 4 months early on as well. The idea being that even if you don't get endovascular therapy in the study, the team is required to review your care and look at the compression therapy and look at what else you're getting and modify it and tweak it so that they're still being actively managed, even if they didn't get endovascular therapy. Because I think that is going to be important, in retaining them in the study.
And how long is the study going for? And how long? 2 years?
2 years.
Okay.
Yeah.
So the patients that are randomized to non-intervention, they cannot be intervened on for 2 years? Is that what you're saying?
Well, the study protocol would strongly discourage it, and strongly discourages it. If, however, we realize that you can get into situations where the patient is absolutely insisting on something, and where you cross an ethical boundary a little bit, right? So there is the potential for some people to cross over if needed. We certainly don't encourage it from a study perspective, but we realize that is something we may have to contend with, and certainly with this population, it's likely that we may have to contend with it.
All right. So talk to us a little bit about the endpoints that you're measuring.
Yeah, the primary endpoint is the venous clinical severity score. at 6 months after randomization, adjusted for the baseline score. So, so basically, it's the change in essence, in the severity of their venous disease. We're also assessing the Villalta scale as a secondary measure of post-thrombotic syndrome. We're also assessing health-related quality of life using both venous disease-specific and general health-related quality of life measures. We're also assessing and measuring the venous ulcers that people have and reporting out, the percent that the wound healed and how many healed completely within 24 weeks. We're also reporting safety issues and occurrences of recurrent venous thromboembolism, major bleeding, and anything else. We're also doing a health economic study as well as part of this over the 2 years.
All right, great. I mean, that's a lot of stuff measured. Now, one thing you didn't mention, and I agree with you, it's not a primary or secondary endpoint or whatever, is when and how are you assessing stent patency in those people who receive a stent? Or are you?
We are. We're assessing it with ultrasound at 6 months. And again, we're doing ultrasound assessments in all patients in the study at 6 months and at baseline. In terms of any more invasive assessment, we're not doing anything invasive during follow-up. And in that sense, this is very different than, for example, a study that's aimed at getting a stent approved by the FDA, for example, where you're really focused on the device. We're really focused more on health outcomes with 2 treatment strategies, of which stenting is part of one of the strategies.
Yeah, no, and I agree with you. And I think we're all moving to that when we're talking about studies like this, as you said, aside from trying to get a device or a stent approved. And I think quality of life is the thing. Now, so you're only assessing stent patency at 6 months, or nothing prior to that? Is this correct? You're not imaging the stent prior to that?
Correct.
Okay. And I'll go back a little bit. One of the concerns with the ATTRACT trial was the assessment of the disease and the assessment of the efficacy of the stent, stenting the full disease, etc. Some people felt more IVUS should have used intravascular ultrasound. Are you assuming everyone who's putting the stent in is going to be using intravascular ultrasound?
So we are requiring sites after the stents are placed to use IVUS.
Okay.
Before the stents are placed, they're strongly encouraged to use IVUS, but it depends. Sometimes it's more important than other times, but certainly after they've placed them, we want them to use IVUS and look and make sure things look good. Yeah,
no, I agree with you, because many times pre-stenting, you kind of know there's a disease. It's not, you don't need the IVUS to say this patient have occlusive disease or not. But certainly post, I agree. You want to make sure that stent is as open as it can be.
Yep, absolutely.
All right, so you go into 2 years, and what do you hope to find? Yeah, I'm not asking you to predict. If you had your druthers.
Sure. Well, I mean, I think we're always motivated to want, what we want most of all is whatever it is that we find to represent what actually occurs. But having said that, it would be delightful if the study validated a new option that is able to actually reduce disability in this population, right? So if we found that the venous clinical severity scores were better, that health-related quality of life was better, that ulcers heal faster, which is complicated. It may or may not occur. We don't know. And also that the results were sort of sustained, time-wise. We anticipate a relatively low frequency of complications with this particular treatment. But I think that really it's the efficacy and that is determined partly by the stent patency as well, obviously, over the first 2 years, right? So I think that if we find that the people are doing better at 2 years in their venous clinical severity scores and quality of life, then I think we've really achieved something in terms of providing a strong foundation to advance care in a particular way.
Yeah, no, I agree with you. And I think many of our biases are that placing the stent in the right patient does improve their quality of life, and
Sure.
That's our bias, but that's why you're doing the study, and I think it's great, and I think it is a more, I think you learned a few things from the ATTRACT trial. It's a more narrowed, uniform type of study, and as you say, you're addressing a disease that can be quantified a little bit more. I mean, you know it when it's there. It's not, you know, and you're only dealing with from the inguinal ligament on up, which I think is good as well. And I think it will help us a lot. Anything else you want to say to the listening or public about the trial or anything?
Well, I think it's a great opportunity, and I think actually even the ATTRACT results point in the direction that this may be a great opportunity. We just published the iliofemoral subgroup paper for the ATTRACT trial in Circulation in December, and that trial, again, it found that even in the iliofemorals, lysing people up front doesn't prevent PTS, but it does reduce the severity of PTS. It improves their quality of life more than standard therapy does, and so I think with that in mind, the idea that having an open iliac vein is important to patients' quality of life is something that we're now assessing in a different context here. And I think that were this trial, for example, to be positive, then I think the next step would be, okay, we really need to make providers aware of this idea that an iliac vein needs to be kept open. Right. And again, we need to develop that evidence, but I think that would be a very exciting advance in care if it were to happen that way.
No, I think you're right. And, I think it's great. I think, you brought out all the points about the trial, and now let's hope that this will also add to people submitting patients for the trial. So Thank you, Suresh. Thanks a lot.
Thank you for this terrific opportunity, and it's always a pleasure.
All right. Take care.
Yep. Take care.
Bye.
Bye-bye.
Don't hang up yet. Hang on, Suresh. Don't hang up. Okay. So Rebecca's going to stop. Rebecca, can you come back on?
Yep, I'm here.
Okay.